For those of you who are coming in from the waiting room, thank you so much for joining us for today's webinar. Please remain on mute as we go through the webinar today, and you will be receiving a copy of all the slides and the recording and all the information you need to claim CME credit at the end after the webinar in a follow-up email. Thank you all for joining us for today's webinar, Youth Depression and Suicide, Prepare for the School Year. I'm Kristen Flewitt, the Senior Quality Manager at the Ohio Chapter of the American Academy of Pediatrics. We want to thank the Ohio Department of Health and Ohio Mental Health and Addiction Services for all the support on the webinar and in partnership with the work that we are doing. A couple of housekeeping items that I just wanted to mention. Please remain on mute to minimize background noise. We love to see comments and chats in the chat box, so feel free to chat in comments and questions. And a link to today's slides, a recording of the webinar, resources, and a link to claim CME credit will all be emailed to you. Just briefly to review our agenda, I'm going to go through our objectives and we'll do a brief, again, if you wouldn't mind to check if you are not speaking that you are on mute. We're getting a little bit of background noise. I will do some brief presenter introductions. Dr. Gilman will review the current status of youth depression and suicide in Ohio. Dr. Emily Harris will be reviewing screening and strategies to address youth at risk for death by suicide. Dr. Sarah Denny will be reviewing resources for families and youth, and Dr. Ryan Kaufman will be reviewing depression screening in medical settings, opportunities and challenges, and then we'll have a brief wrap up. Today's objectives are to be able to describe data around rates of depression and suicide in youth and why professionals need to discuss safe storage of lethal means with youth and families, being able to identify screening and intervention strategies to address youth at risk for death by suicide, and identify resources for families and youth. I'd like to introduce today's presenters and thank them for all of their incredible work. Dr. Mike Gilman is a pediatric emergency room physician at Cincinnati Children's Medical Center, and he is a professor of clinical pediatrics at the University of Cincinnati School of Medicine. In his service at Ohio AAP, he has developed a statewide bicycle helmet intervention program, a hospital-based safe sleep QI program, an injury QI program for practicing pediatricians, and he is a co-medical director for a lethal means safe storage program that includes youth suicide prevention at the Ohio AAP. His area of research expertise has been to study the impact of screening and counseling families about injury prevention in the office and emergency room setting in an attempt to promote safer behaviors and prevent future injuries. He has published his efforts extensively in peer-reviewed journals. Dr. Sarah Denny works as an attending physician in the Division of Pediatric Primary Care at Nationwide Children's Hospital and is an associate professor of pediatrics at the Ohio State University School of Medicine. Dr. Denny sits on the board of directors for the Ohio chapter of the American Academy of Pediatrics and is the co-chair of the chapter advocacy committee. Dr. Denny is a co-medical director for a lethal means safe storage program that includes youth suicide prevention at the Ohio AAP. Dr. Ryan Kaufman is a board-certified family physician who founded Hickory Medical Direct Primary Care. Dr. Kaufman is past president of the Ohio Academy of Family Physicians, and he has served on the American Academy of Family Physicians Commission on continuing professional development. Dr. Kaufman is a CME committee chair and the Quality Improvement Physician Champion for the Ohio Academy of Family Physicians. Dr. Kaufman is an associate medical editor of Family Physician Essentials and editor of the Ohio Family Physician. Dr. Kaufman has written and presented regionally and nationally on a variety of topics, including mental health in adults and children. And Dr. Emily Harris graduated from the Pittsburgh Triple Board Program and is board certified in pediatrics, adult psychiatry, and child and adolescent psychiatry. For over 10 years, she has worked as both a primary care and foster care general pediatrician, as well as an outpatient child and adolescent psychiatrist. She is an associate professor of child psychiatry through the University of Cincinnati School of Medicine at the clinical affiliate Cincinnati Children's Hospital Medical Center. Dr. Harris has a strong interest in supporting pediatrician mental health education and integration efforts that will help pediatricians improve a child's entire health. Dr. Harris is providing psychiatric expertise as a mental health consultant for a lethal means safe storage program that includes youth suicide prevention at the Ohio AAP. I wanted to note that today's presenters do not have anything to disclose or conflicts of interest. And with that, I will turn it over to Dr. Gilman.
Thank you, Kristen. Excited to be here, and I hope that everyone that's attending the call today at least learned something about kind of why this program is so important and kind of some things that you might be able to use after you hear all the material. Next slide. So I always like to start off with a case. Unfortunately, this type of case happens all too often, but maybe it'll hit home a little bit and make people at least understand some of the problems that we see. But this case is a 15-year-old boy who went to their primary care provider. He needed his sports physical to be completed. During that time, they discussed that he was a little bit overweight. They discussed about sports readiness. He was turning 16, so they talked about driving safety. And they did a HEDS assessment, which looked at like home education activities, but there was no screening for depression or suicidality. There was no mention of home firearms or lethal means storage. And there was no discussion of recent stressors and coping skills. Next slide. Unfortunately, EMS presented to the home of your patient after they heard shots fired. A 15-year-old male was found dead with a single gunshot wound to the head, and he was pronounced dead upon arrival. Next slide. And some of the lessons that you can learn from this is the family had a firearm stored next to the parents' bed in a nightstand. The teen just broke up with his girlfriend that evening. He was known to be impulsive, and he was having more problems in school and home over the past few weeks that he did not disclose to others. Next slide.
So I believe this is the point where we're supposed to launch our polling. I wanted to ask Liz and Haley if you might check to see if you can launch the poll. I think that with our login, something has affected being able to launch the poll.
I do not have the poll.
I'm just getting a message that says I've logged in from another device and the polling session is inactive.
That's okay. Kristen, I can just go on if you want.
Okay, sure.
Let's just go to the next slide. So, in this lesson that was learned of this patient is that, unfortunately, if we're not screening and these kids are so impulsive and they have lethal means access to them, we need to be able to do something, right? And so when you take a look at the leading causes of death for teens, because when we discuss anticipatory guidance, what we're trying to do is reduce morbidity and mortality to the youth that we care for. So, of course, the leading cause of death for teenagers is always unintentional injury. In fact, between 1 and 44 years of age, as you can see, unintentional injury causes more deaths than all diseases combined. However, if you take a look at the next is suicidality. And suicidality is up there, especially in the ages of 10 to 34 years of age. Next slide. And what's interesting is when you talk about what is the leading mechanism to cause death, it's always been motor vehicle collisions. So when you look at the population of 15 to 24-year-olds, mainly that teenage population, it's always been motor vehicle collision deaths. But now look underneath it. We now have suicide by firearm, homicide by firearm, unintentional ingestion, suicide by suffocation. So suicidality and the use of firearm is significant in causing death to our teenage population. Next slide. And when you take a look at the firearm death rates by intent for specific countries, right? Look at the United States. The United States has significant amounts of firearm deaths compared to all the other countries. In fact, the United States accounts for 91% of children killed by guns in all high-income countries. So other countries are doing something right that we are missing as a country. Next slide. And just looking at some numbers, okay, so firearm problem for US children and teens on each year. So it accounts for about 1,800 deaths, and homicide is about 3%, but suicide is 38%, and it's up almost 50% since 2013. And what's also sad is it's an 80% increase in suicides among kids less than 14 years of age. So we are seeing, kids that are coming in that are younger and younger, and they're all reporting that they have suicidality and or depression. And then when you take a look at the non-fatal injuries that require ED visits, it's about 7,800 kids each year. And since 2007, ED visits for self-harm increased about 329%, and all mental health disorders are up 60%. In fact, in the ED that I work in right now, when I started, maybe 20 some years ago, we saw about 600 to 700 psych eval patients a year. We see about 600 or 700 psych eval patients a month currently. Next slide. And when you take a look in Ohio, the suicides are continuing to increase. So we're almost at a 30% increase in suicides by year since 2010. And unfortunately, these are occurring when you take a look at the demographics of these patients, they are occurring anywhere. It could be in rural areas. It can be in more urban areas. And so it is happening pretty much in many different communities all throughout the state. Next slide. And unfortunately, about half of all homes have a firearm, which accounts for about 200 million guns, and the majority of these guns are handguns. Now, only 37% of households report a firearm within Ohio, but again, when they do more polling, close to 50% report that their gun is unlocked and it could be loaded in a location that is accessible. So now we're talking about these impulsive children that have access to firearms. Next slide. And Art Kellerman, he's in Atlanta, he's an ER physician, has done extensive work looking at firearm risks in the home. And he's done some research and he's found that the risk of suicide in a home with a gun is about 5 times higher than without a gun. The risk of homicide in a home is 3 times higher if you have a firearm than without a firearm. And the risk of a fatal shooting of a household member is about 22 times higher than it is of killing an intruder. So the access of firearms in the home increases the risk for suicide, homicide, and fatal shootings. Next slide. And of youth who completed suicide by a firearm, about 82% used a gun from their own home. So if you think about this, it's not like they're going out and purchasing guns. It's where they know that they have access to a firearm, they are going to use it. And it's commonly a firearm that's in the home, or it might be a firearm that they know that grandmother has, but it's one that it's usually a family member and one that they know that they have access to somewhere. Next slide. And again, so unfortunately, the presence of that firearm in the home, okay, increases the risk for even those kids without a psychiatric diagnosis. So you might say, well, my child doesn't have a psych problem. I know them and I've never worried about it. But the studies have shown 25% of teens are depressed at any given time. So if you think about it, your child is doing well, they're not having a problem, The next week, their significant other breaks up with them. They now are upset. They now see stuff on social media. They now feel like life is over. And now all of a sudden they are depressed. Nobody knew about this, and they're incredibly impulsive. Next slide. And when they've done studies looking at time elapsed between a decision and an attempt, they interviewed survivors of near lethal suicide attempts. And what's interesting is they'll say 25% made an attempt within 5 minutes of the decision, 50% within 20 minutes, and 71% within 1 hour. And most made that decision within 1 hour of the crisis, which is either a fight with a family member, a fight with their significant other, a breakup, a problem within school. So the idea of lethal means restriction is if the child has this thought, you need to be able to make it so they can't have access to something that causes lethal means within at least an hour. Let time go, let them not have access, and you will actually reduce the number of suicides that will be done by completion. Next slide. And when you look at common triggers for suicide patients, you can just hit through them, Kristen. Bullying between peers, especially over repeated time, often causes children to be depressed and the risk for suicide. And it can lead to lower school performance and detachment from others, which might be a sign that you know that your child's having a hard time. Next slide. Internet usage. Keep going. And so studies have shown that if you more than 5 hours of video or game or internet time used daily is associated with higher levels of depression or suicidality. Next slide. Increases in stress in school and at home. Next one. And so, for example, many of our teenagers are experiencing problems with COVID. And so that's increased the stress at home and in school. And many of them feel that there's no way out. And so they are depressed and have suicidal thoughts. And then recent attempts by self or others is also a common trigger for a suicide patient. Next slide. And so counseling by all involved teens. So we must screen and ask about depression and suicidality. Lethal means counseling is essential by all, and community resources and mentoring is so important. So if we go back to the case that I presented at the very beginning, what if that teenager was screened for depression and suicidality? They screened positive and they actually were sent for resources. What if lethal means counseling was discussed at that visit and the patient and the family went home locked up or got rid of that firearm and the child didn't have access? What if there were resources available to that family and they could get in right away? All of those things would have prevented this catastrophic event that we presented at the very beginning. Next slide. And I will turn it over to Dr. Harris, and I'm happy to answer questions in chat as Dr. Harris talks.
Thank you so much, Dr. Gittleman.
Hello, everyone. Thank you for having me. And that was a great way to lead into, what do you do? How do you handle it when you are presented with a child or anyone with risk for death by suicide? And I'm going to go a little bit further into what do you do? Oh, I can't advance the slide, please. So NAMI is the National Association for Mental Illness. It's an association for families and people with mental illness to gain information about what they can do to help, how to support, how to help each other. And I don't know if you're familiar in pediatrics, the American Academy of Pediatrics has endorsed like a language around talking to families and youth around sensitive topics. And these were the information in that box about the 5 action steps to help someone in emotional pain is like a visual reminder of what to do in these moments or how you can kind of be aware and help. And the idea of help is like how you do that. So, offering hope or eliciting hope when you're talking to someone, listening with empathy, using their language, being really invested in their ability to get, or their commitment to get better, like the recovery, asking permission to give information, not just telling them what to do, like it's really a partnership, and it's like a shared idea of a plan that's going to have the most impact on aligning yourself with a family and a shared decision-making model. And, you know, when people say things that are very distressing, it's often, you know, what do you do? So like acknowledging like, this was really, you look like you're really uncomfortable. It looks like very stressful for you. Thank you for telling me, you know, talking about bravery, and that no matter what the issue is, like suicidality or some other like really intense topic, the concept of like, my goal is to, my concern, primary concern is safety, whether that's emotional safety, physical safety, environmental safety. We're all trying to keep kids healthy and safe. And that's the kind of the frame on which you can like rely to address issues. But the NAMI came up with this idea of youth voice. They want, when they come to visits, and these are like medical visits, it could also be at the school or whatever, but the medical visit and the medical home, you know, engage them during the visit, talk to them is what they want to have, and ask them about how to communicate, like what would be a good way that they could reach out to someone. What are they actually going to do? And listen. Often teens don't feel heard during visits like this. Often they shut down because they haven't been heard. So just recognizing those signs that I can tell people haven't listened to you. What do you have to say? How can I help you? Or what can we do right now? You know, how to tell me what this is like for you, kind of concepts. And providing information is really helpful. You can go to the next slide. Adolescent brains are one of these unique times where you know, the emotional center, like the amygdala, is like kind of gearing up as well with all the hormones that are happening. And the prefrontal cortex, that last part of the brain to develop, is still developing. So it's not quite there yet. And the adolescent brain is uniquely wired to have a propensity to go towards that reward system, like what feels good, what makes sense. And it has like this emotional ability associated with it. The great thing is that they can now have a different understanding, a more broad conceptual understanding of life, and, you know, communicating why you're recommending these things and focusing on safety, and just reinforcing that it's brain health is the idea, and the messaging that you want to send goes a long way. And this is at every risk level of suicide. And we're going to get into like how to assess that in a minute. But I just wanted to pull through, no matter what the issue is, these are actually from the guidelines for health supervision for the American Academy of Pediatrics, but the idea of resilience. And these are really the elements that honestly were largely taken away with the pandemic. The idea to practice these social skills, practice emotional regulation, developing those strong connections and attachments in a healthy way, you know, kind of finding these coping strategies and having self-control. This whole generation is like at a disadvantage, or they're going to need more practice than previous generations. So it's kind of our opportunity to jump in there. And I'll go to the next slide to talk about it. So again, like these are kind of like the building blocks that I'm doing for the actual interventions, but in any capacity, the idea of like, you know, if someone's presenting with suicide or risk of suicide, suicidal thoughts, you know, the idea of addressing, like as a medical clinician, you know, addressing their underlying mental health diagnosis is going to be helpful. Impulse control is a big one, ADHD. As Dr. Gilman was saying, like impulsive decisions are most of the time being made when you're thinking about wanting to die by suicide. Depression certainly doesn't help, it's there, but also anxiety too has a risk of suicidality and suicidal thinking. So thinking about those things with evidence-based treatments, and, you know, the idea of working through and rehearsing your, like kind of practicing and kind of rehearsing these social situations, like what happens when you're distressed, what are you going to do? How are you going to let somebody know is something that you have to consciously do, as well as you know, thinking about what's the healthy coping strategy instead. So when you're having these thoughts, or you kind of know the situation that's going to happen, when they do happen, you know, what can you do instead? You always have a choice. There's always a choice not to act on the thoughts. you do have this heavy feeling, what are you going to do with it? And that's when we talk about these like brief interventions that you can teach or kind of model with them is how to reset this overactive sympathetic nervous system. How do you calm your mind? How do you return the blood flow back to the brain where it should be and get that like calming pathway to start versus that fight or flight pathway that's really, really high when you're distressed. And I'll go through specifically at the end when I kind of pull it all together. But next slide. Yeah. So when we're talking about how to address formally like suicide risk in pediatrics, we're talking about like identifying risk, managing safety, and developing a plan for next steps, like what to do. The safety plan, it's not a safety contract, it's a plan. Kids cannot make contracts, they can't consent, they can assent, but they can't consent. And promises aren't what we're going for. It's actually like not saying you're not going to do it. It is, okay, so if this happens, here's what you're going to do instead. Here's how we're going to manage things around you to reduce your triggers. This is how we're going to protect you and keep you safe. And you have to help us help you keep you safe. And these are some healthy coping strategies to do. So this idea of restricting lethal access is critical to the safety plan. Next slide. So thinking about risk, he mentioned some, strong sense of hopelessness actually is a very high risk factor concern about death by suicide, or at least suicide attempts. High degree of family conflict is another big stressor that can happen. If they have a very severe mental health disorder or frequent thoughts, or if they've made previous attempts, puts them at much higher risk. And anything that kind of will affect your ability to have rational thoughts. So like your substance use or psychosis of disorganization and things can impact your safety and your risk for death by suicide. Thinking about things that are protective are past pattern behaviors. So when they've had thoughts and they didn't act on them, highlighting those moments, reinforcing those positive things that happened are very important to help develop these protective factors to counter. And their ability to tolerate and engage in the process of coming up with a safety plan is another sign that this is good and that they'll be able to be actively involved with helping keep themselves safe. And obviously the opposite of high family conflict is high family support and cohesion, and the ability to have supervision are all incredibly important protective factors. And we are more familiar too with what factors are present, but they raise caution. It might make you want to screen more or more often for suicide risk of any sudden loss, especially like a same age peer, family member, parent, any kind of significant loss, animal, anything. Family death by suicide is another high caution when we are working with children. And isolation from a group. So social connectedness is one of those resiliency protective factors, and having isolation from a peer group or even significant other raises concern, and you should start screening for thoughts of suicide and violence exposure or abuse. But really this dysregulated and poor impulse control is nearly ubiquitous, but that concept is high risk for making a very poor decision in a quick moment. Next slide. All right, so there's two main tools to use. So when you're formally universally identifying suicide risk, and there's the ASK, which is the Ask Suicide Screening Questions. And it's a brief tool that is developed for non-mental health trained personnel. It can be administered by a nurse. It can be administered by literally anyone. But it's been validated in all healthcare settings and recommended for all patients actually that are being treated for mental health issues, but also that are in inpatient hospital stays. This has been validated to use. It is just a few questions, and it kind of goes down this risk severity ladder, so to speak, about risk of suicide. And if they have a yes to any of the questions in 1 through 4, then you ask number 5. If the first 4 are no, then you don't have to ask number 5. And then you can go with the preventive messaging around suicide risk. Next slide. So when you're administering, as I said, like if you answer no to all of the first 4, like having any thoughts about wanting to die, have you actually had any active pieces or, other things like that. If they answer yes, and they have, you ask number 5, which is, are you having any thoughts like that right now? This is considered a high risk child and an imminent risk. And the idea of not leaving them unattended is incredibly important, and having them same day, if not like next, be evaluated immediately for a safety evaluation to appropriately figure out the level of care that's needed for this child. If they say yes to everything but no to number 5, then a brief suicide assessment screen is then done to determine how quickly they need to go to a full mental health evaluation by a trained professional.
Dr. Harris, we just had a quick question in the chat.
Sure.
What is the lower age limit that the ASQ has been validated for?
I believe it's like, I have to go back and look. I noticed it wasn't on the slide, but I believe it's like 7 or 8. It's actually pretty young. The American Academy of Child Adolescent Psychiatry recommends asking you can just ask the child, you don't have to have a tool, but asking child about suicide risk, even as young as 8 routinely. But then again, for psychiatry, it's a high risk population because they're coming for a mental health visit. But I do believe this is pretty young that it goes down to, but I'll triple check.
Thank you.
Mm-hmm. Next slide. So the second version, or the second screening tool, that is technically not validated, but best practice use in many situations and organizations, is the Columbia Suicide Severity Rating Scale for primary care. It's a brief screen. There's also a longer version that is 3 pages of fine print questions that someone with training administers. But this 6-question tool is very helpful because it also gives you not just the risk level, but then what do you do with that risk level? So there's low, medium, and high, like yellow, orange, and red. And it talks about what to do in those moments. So if they have, any intent is huge, and detailed plan is huge, in addition to any recent behaviors. So planning to do, started to do, or practiced anything to end your life within the last 3 months is considered a high risk. It's still moderate risk if it's been longer than 3 months. If they've only had a method, like how have you thought about doing this, that's a moderate risk too. And we'll talk about what to do with that. Next slide. So thinking about your clinical response, low risk is not no risk. There is never no risk, but low risk still requires intervention. So you still need to say you are at risk, and here's the concerns I have. I want to get you connected to treatment, which was that first piece of treat the underlying mental health problem, or address the distress, like treat the problem that's happening, either a school situation that needs to be addressed at something, offering the positive coping strategies with the adaptive coping strategies. And if they do have a therapist, have you talked about this with your therapist? Is this part of what your treatment is? Or is this new? Is important to know. And if they're not with a therapist, then referring to a mental health or behavioral health specialist is recommended. If they do have a method, or if they've had any type of acts of furtherance or behavior that's been longer than 3 months, then according to the Columbia Suicide Severity Rating Scale, if they have a treatment team, you let them know, hey, this is what information I have, so that they can also adjust their treatment plans accordingly. But then that you want them to be seen within a few days. Like, these are kids that they've had a method, but they don't have access. They don't have intent. They've never acted on those thoughts. They just are like, this is what I would do if I do it. So these are the kids that are more a more direct safety plan that can happen in a primary care office where you're looking at those lethal means, increasing supervision, communication strategies, and coping strategies are part of that plan. And then they can potentially go home and go to the therapist the next day for a more extensive mental health evaluation. Honestly, the ones in the red box, like the high risk children, they've endorsed intent or even a vague inferred intent. Like I took 27 melatonin 5 days ago because I just wanted to sleep. I find it hard to think that they thought they needed 27 melatonin. So from my perspective as a primary care person, I would then want to definitely have a psychiatric evaluation or mental health evaluation, a full one that same day, and keep the child within constant supervision on their way there, because it's still a very high risk behavior. Any acts of furtherance, especially recent things, should have a same day evaluation as well. And if they have a treatment team, then that's what you need to inform them and trying to get them in with the treatment team. And if not, if they can't get in, then your local appropriate measures for getting an emergent evaluation. Usually it's in the emergency room, but I know that in different parts there's different clinics or mental health walk-ins, things like that, that can address the child immediately. Next. So safety planning, it's better to do it in the office because you're not in crisis. It is not good to come up with a plan when you cannot think. So when you're in crisis, again, these are really unpredictable things. It's everybody, like you could be fine and then not fine. And it's hard to know what's going to happen in life. I think, again, the pandemic has showed us that. So it's important to prepare and kind of be prepared and be thinking about it. And that's why I really like the Store It Safe program, because like having this lockbox or having a way to restrict access, I'm sure your kids are going to be like, that's a challenge, but it's not meant to challenge the child to open it. It's meant to kind of make it harder to get to, so that they have that delay, they extend that time before they can act on those thoughts. And it gives them time to calm down and to re-regulate their brain. So the idea of restricting access with a lockbox is to not make it a game, but really to just make it harder to get to. And those moments, as you saw with Dr. Gilman's research or data about the 50% of people within like 30 minutes acted on thoughts of wanting to die. And if they had restricted access to it, it would decrease the ability to act on the thoughts. The idea of giving time to regulate your brain again so you can think is incredibly huge. And this idea of natural buffering, having these communication pathways, these coping strategies readily available so you don't have to think of what to do, is the other part of why safety planning works and why you have to do it ahead of time. And it gives you something to do, like especially for caregivers who are then like watching or knowing about this event that happened, that they had no preparation, no idea that it would be happening. And that's the largest fear for most people, is that something happens to their child and their child's safety. So this idea of safety planning gives you a way to approach it and with the team themselves. Next slide. So those important components of it, the first plan is like the restricting access and increasing adult supervision. And these were that's like a picture of the lockbox that is through the Store It Safe program. And you can put medication in this, you can put like alcohol in this, you can put like whatever you want in it, but just the idea of those things, like alcohol can impair your judgment, like that should be not openly accessed to adolescents who are at high risk of making really bad decisions. And risk-taking behavior is kind of part of it. But, offering and just kind of reminding parents that these substances can be really disinhibiting, and which puts risk in or safety, environmental safety concerns there. And that's something that they can do, is to kind of go around and figure out what needs to be changed in the home. the idea of the caring adult person, like the third party adult. So it's not necessarily the parent, but it's obviously ideal if it's the parents that are in the home. Sometimes parents are like overwhelmed for whatever reason that they have, that they don't want to think about it, or they just feel so guilty that this happened that they literally can't be the caring adult that is the one that's doing the supervision. So ensuring that like at school, there's somebody there that they can go to, that they have a plan about who is the point person, if there's like a cousin, or if there's like an aunt or someone who can provide this like just management of supervision for the child as whatever time period that is appropriate, like who can help, who's an adult 24/7 when someone has like suicidal thoughts is the idea behind it. Next slide. Oh, and I apologize. I wanted to say when you're going through the safety, and part of it is like removing the access. It's not, I'm going to go through your room and find everything, because then it's like a game for the adolescent to hide it. It's like, I want you to go through and show me what things trigger you to want to hurt yourself. And then they'll like show you the different things, and you can, it's much more effective to do it with the person rather than to turn it into a punishment, so to speak. The idea of communication strategies, the goal is to avoid situations that perpetuate the suicidality. So reinforce communication when it's hard to talk about it. And the idea is to reduce isolation. So if the child is having a hard time and they're having thoughts, but they don't want to talk about it, that's okay. They can go sit with their parent in the room. They can just do something that would be not isolating, but it's like a nonverbal communication strategy, so to speak. Texting is a great way for kids to talk to parents without talking to parents. But you do want to have them list at least 3 people they can reach out to. And there's apps on the iPhone. There's multiple apps on different things, but it's actually on the iPhone is My 3, which is like the 3 contact people that you just push that face and it contacts that person and says, hey, I need to talk to you now. And you want to have 3, and always warn the parent. The parent may not be the first person they do, because what if it's your parent that you're having a fight with? And then they're your only support person. So you need to have 3 people at least. And then you have contingencies, like what happens if their phone breaks? What would you do next? Like, what are the things that happen? What if you're at a friend's house? How would you work through this? Next. And I'm almost finished. So if you have time to do those things, these are some questions that can help set you up for, what risk this child has, but also what strengths they have. Did they tell anybody? Have you talked about this with your therapist? The main question or the main concept is, what would be an ideal way someone could help support you if these thoughts return? And having them articulate what works for them in front of the parent, I think, is actually the most effective way to do the safety planning communication strategy. That way the parent's not asking the child every 5 minutes, how are you feeling? Are you safe? Are you safe? Are you safe? Every 5 minutes, because that's not ever what the child says that they want to see happen. Next. So safe choices, that just kind of summarizing, pulling it all together, identifying and addressing impairments from mental problems, helping the youth have a positive coping strategy to do in those moments to kind of bring the thoughts back to regulation and to thinking again is a really important part. And then the idea of motivational interviewing to help you to plan. When we're doing these plans, it's like, eliciting information from them, like talk to the patient. What are the triggering situations that lead to these thoughts or behaviors? Because if we can kind of change the likelihood that you're in this situation, we can reduce the idea or the behaviors that might happen following. So you elicit the information from the team. You can offer information about, hey, did you know that isolating or thinking about this over and over again kind of reinforces this and reinforces your mood? Let's come up with some other strategies that we can do when these thoughts happen so that you can see if it works to feel better. What do you think about that? Or what could you do instead of sitting in a room and isolating and not talking to anyone? And then, the child comes up with things that are more active and proactive for their own self-management skills. Next. I think something else going to happen. So the last thing is this mental health action plan is like what to do next. So you have these key components of your safety management plan, and it's not enough to just have that safety plan. You have to have a follow-up what to do with it. That is critical too. So you've like restricted lethal access, you know the warning signs and triggers, you have your interventions in place, your connections, you have the safety of the home and their different environments set up, the communication strategies and supports. Steps to do when you're in a crisis, like when you're feeling this way, this is what you can do. And then if it's not better, I want you to do this next. And then if this is happening, this is like the plan of calling. So like setting up their own little algorithm of what to do when, and having some healthy, flexible thinking, coping skills to offer in crisis resources. And the last slide are some national crisis resources that we have. So the My3 we talked about, 741 and 741 is the national crisis text line. And I also have the Trevor Project for LGBTQ plus teens. If you guys haven't been on this site, I highly recommend it. The very first thing it says is, here is the kill switch to get out of this website. If a parent walks in the room and you do not want them to see what is happening, like this will help delete the screen quickly to help keep the kids safe who are not in a safe environment in terms of like feeling good about disclosing what they're going through or what they're thinking about. But these are wonderful resources as well, and whatever local ones you have for your community.
All right, thank you so much, Dr. Harris. We do have a question in the chat box, if you wouldn't mind to
Sure.
take a look at that. I thought we would just let Dr. Denny get started while you address that question. So with that, we'll turn it over to Dr. Denny.
Hi, thank you guys all so much for joining. And Dr. Harris, that was amazing. Thank you so much. I feel like I see teens every day in my office. We do the screenings, and I feel like this just really helped me feel more confident in managing those patients who are struggling or who are in crisis. So thank you. That was fantastic. And we just wanted to go over briefly some resources that are available to all of you. Dr. Harris just posted on her picture or on her last couple screens some helpful text numbers and other resources for you to have. They have done studies, as you all know, since you all work with adolescents in one way or the other, that teens like to text. And so they are more likely to use a text option as opposed to a phone call. So we always like to provide those text options for them. So the Ohio chapter, the American Academy of Pediatrics, and the Ohio Association of Family Physicians are also working together on a youth suicide prevention project called Store It Safe. And this is a quality improvement project in partnership with Ohio Department of Health and the Ohio Mental Health Association to really encourage providers to increase screening for both depression and suicide. These are two separate screens at every primary care, well child, or sports physical, so that we are able to screen these patients, identify these patients, and then give them an intervention or referral or link them with resources. So this is a really exciting learning collaborative that we have going on. And if any of you are interested, we'd be more than happy to talk with you after this call. But we have a lot of resources that are geared. We have some for providers because this can be sometimes challenging to talk about. And if you're not comfortable talking about it, we kind of have some scripting that you can use that can help out, but then also resources for families. And then we also have resources for youth. This is not necessarily just for healthcare providers. Like if you're working in a school and you want some of these resources, I would definitely encourage you to check out what we have. Next slide, and I'll talk you through a little bit about these resources. So these are for providers, kind of just talking about the screening, talking about ways that you can talk about it. And then but the back side of this sheet is just an example flow chart of how you may want to implement this into your practice for those preventative health visits. So the adolescent well child visit, as well as the sports physicals. And then a very rough guide about what to do, because I think one of the things about screening is, okay, great, I screened, but now what do I do? And so kind of walking you through just some suggested steps. Now, obviously, every clinic has its own different resources. Some have a psychologist and a social worker and lots of mental health support, and others have none. And so obviously everyone needs to adapt this for its own, for your own separate setting. Next slide. The other thing is the family resource. And I think Dr. Gilman and Dr. Harris both really reinforced that this discussion is not just for the child who has a history of depression or that child who has some anxiety or some other mental health diagnosis. This is for every teen. You don't have to have a history of mental health issues to commit suicide. And so this is an ongoing discussion that families should be having with their adolescent, and kind of having check-ins and making that just something that the family is comfortable talking about. And so the child knows that those lines of communication are open. And so this is a handout designed specifically for families to think about, one, talking about those emotional triggers, that adolescent brain, and then also thinking about other risks. So firearms are one, but that's just one of the lethal means that are common in households. Medications, over-the-counter medications, alcohol. How can we keep kids safe? And so it also just goes over some of the things at a very high level that Dr. Harris went over, as well as the resources, some suicide warning signs, and just really reinforcing that prevention, or that message that this is really for all teens, not just for ones who may be more at risk than others. Next slide. And then we have these rack cards. So the one on the left-hand side of the screen is for parents. So this is the reversing a trend of irreversible actions, where it kind of talks about restricting those access, planning ahead. You don't want to wait till your child's in crisis to come up with a safety plan. That needs to be done in advance when the child is calm. And then just understanding that a crisis may happen. And so what are you going to do if that happens? So are you going to, identify those five senses, grounding techniques? Are you going to, is the teen going to reach out to one of their three? What are different things that they can do in that instance? And then we also have the back card on the right, which is specifically for the teens. And we actually design these with input from many adolescents. And so, try to get a good balance of appropriate information without making it too overwhelming, but also providing stuff that we thought was actually useful. So again, starting off right off the bat with those text lines right at the top, talking about, what to do if a friend comes to you. If you think about it, if you're 15 and a friend comes to you with that kind of information, if they want to hurt themselves, that's a lot for that 15-year-old, right? And so like, what should you do if it's a friend? But I think that also using the friend is a good way to kind of enter in this conversation to also be talking about the teen in front of you. And also just kind of thinking about some other strategies with the 10 ways to make a break. So these are resources that are free and available to you. And then we're also distributing these as part of our learning collaborative. Next slide. Okay, Dr. Kaufman.
Okay, well, you've heard from everybody some really good information about why this is so important, and a lot of good resources and techniques to be using. What I'm going to talk about is a little bit of what the challenges are and why this isn't happening, because anytime you want to improve a system, you understand why things aren't happening the way that they should be. Next slide, please. So part of the challenge is some of the evidence still isn't there as good as we would like it. So certainly for the older adolescents, 12 to 18, it's definitely there. For the younger children, there still isn't great evidence of some of the benefits of depression screening, and that it actually is benefiting patients. And so that's part of what hopefully we'll have some research to help support that going forward. Next slide. And then kind of what are barriers, and looking particularly from my viewpoint as a family physician, although most of these apply, whether it's a pediatric office or a family medicine office. Fragmentation of care. There's lots of opportunities that people have to get care, and there's good things about that. But if patients are being seen in the urgent care setting, if patients are having their sports physicals done at school, and aren't being seen, it's missed opportunities. So any of these things that fragment care and keep patients away from their medical home, whether that's a pediatrician's office or the family physician's office, that can lead to missed opportunities. Documentation being poorly supported, certainly in a family medicine setting, many of these screenings that are directed towards children are not as well supported in our record systems as some of the things for adults, just because it makes up a lower portion, especially of our sick care. And so making sure that there are ways to easily document and support these visits. Also, heavy loads of chronic disease management. Often insurers have focused on these things, and these are the quality measures that physicians are being measured on. So having a lot of chronic disease management makes it harder sometimes to focus on these prevention measures, which are so important. And certainly practices that have lower volumes of children and adolescents make it more challenging to have educated staff as well as physicians. And then poor availability of support and specialty care for complicated cases. Certainly, as a family physician and as general pediatricians, we treat a lot of patients dealing with anxiety, with depression, with suicidality, all these things. However, there are times these certainly get beyond what we're able to manage with our training and expertise. And especially in a rural setting, like where I practiced my entire career, it can sometimes, the waiting period can be weeks or even months to get patients in for a higher level of care with psychiatrists or other mental health workers, and that can be very challenging. Other barriers that we've certainly all seen is hostility, especially when you start talking about things like guns. It can very quickly become patients can see that as or parents can see that as a political statement, even though you're looking out for the safety of children. So figuring out how to address issues like this and make sure that parents know we're doing this to look out for the child. It's not a statement of should they or should they not be allowed to have a gun in their home as an adult, but how do we keep that gun away from the child? And then the time required for all the very important topics that we deal with. And like what goes along with that is reimbursement. In working with this project, there have been physicians who try to use codes to get reimbursed for giving some of this care and have actually seen a lower reimbursement than they would have if they had never coded that code. And so the fact that insurers don't or often don't appreciate the importance of this and don't reimburse for it in the ways they should. Next slide, please.
Thank you so much, Dr. Kaufman, and to all our presenters today. We really appreciate all this great information. And as I mentioned, everyone will receive a follow-up email with a link to the slides, a link to the recording, and your link to claim your CME credit. I'm always available. If you have questions or need additional resources, please don't ever hesitate to email us. The other thing I wanted to mention is we've done a tremendous amount of work in this space and want to continue expanding that. So we are looking for partnerships with other organizations and professionals in different settings to join our coalition to learn from one another and tackle the very large problem of youth suicide. So I will be getting some information out to you about that as well. But again, just to highlight it on this slide, we're going to have an application process to provide safety lock boxes or the lock bags that you saw pictures of on some of the slides so that you can distribute those in your community. So this is for folks who are in a non-medical setting. Also, some of the resources that you saw and others will be supplied to you and provided. And then suggestions for social media sharing that your organizations can share. And then coalition meetings, again, where we all join together and think about other ways and all the things we can do to try to tackle this very large and concerning issue. So with that, we will be signing off today. Thank you so much again to everyone who joined us. Please be on the lookout for that follow-up email from me. And we'd love to have you join us for additional educational opportunities that the chapter provides. So thank you to our presenters and thank you again to everyone who joined us.